Welcome to This Explainer. Today, we're kicking things off with a genuinely counterintuitive fact about the human body. In a condition known as a ventricular septal defect, the absolute loudest, harshest heart murmurs usually come from the smallest holes. And those quiet, unremarkable-sounding hearts, well, they can actually belong to the sickest patients in the room. I know, it sounds totally backwards, right? But once you understand the physics driving it, the entire natural history of this disease falls perfectly into place. Okay, let's dive into this, because this seemingly backward fact is the absolute key to understanding the entire timeline of this disease. We're talking about a congenital lesion that can go from being just a harmless, incidental finding on a routine physical all the way to an irreversible, transplant-requiring medical emergency. And honestly, the most terrifying part? The transition between those two states is totally silent. To understand exactly how that happens, we need to build the mechanics of this condition from first principles. So what exactly is a ventricular septal defect, or VSD? Put simply, it's just a hole in the interventricular septum, which is the walls separating the left and right ventricles of the heart. Now, think about the basic plumbing here. Throughout systole, when the heart contracts, the left ventricle operates at a way higher pressure than the right ventricle. Because of this massive pressure gradient, blood naturally shunts from left to right. It's just following the path of least resistance, flowing from the high-pressure chamber directly into the low-pressure one. Now, the real secret to this whole paradox lies in the physics of sound. If you have a very small defect, blood is forced through this tight, restrictive opening at an incredibly high velocity, and that creates massive turbulence. Turbulence is exactly what generates sound, specifically a loud, harsh holosystolic murmur that's often accompanied by a palpable thrill at the left lower sternal border. But what if the hole is large? Well, in that case, blood moves between the chambers almost without any resistance at all. Low resistance means low turbulence, which paradoxically means a much softer murmur. Sometimes there's no murmur at all. Remember this golden rule. Murmur intensity tracks turbulence, not disease severity. Confusing those two is honestly one of the most dangerous traps in clinical medicine. Where that hole actually sits anatomically matters enormously too. There are 4 main subtypes of VSDs, and knowing them tells us exactly what to expect. Perimembranous defects are the most common overall, sitting right near the tricuspid and aortic valves. Muscular defects are embedded in the muscular septum itself, and inlet defects are located near the AV valves, which are often tied to more complex abnormalities. But you really want to pay special attention to supracristal defects. These sit just below the pulmonary valve and carry a very specific, dangerous risk. They can cause the aortic valve cusp to physically prolapse right into the defect. This produces coexistent aortic regurgitation, which is a highly problematic combination that we must actively hunt for. Let's move on and see how this builds over time, particularly when we're dealing with a large, unrestricted VSD. You see, a small VSD is usually just a benign asymptomatic thing, but a large one, that is an entirely different disease. Because there's minimal resistance, a massive volume of blood recirculates from left to right with every single heartbeat. This constantly floods the pulmonary circulation and severely overloads the left ventricle, which is forced to receive all that extra blood back from the lungs cycle after cycle. Over time, this chronic volume overload causes the left ventricle to physically dilate. But here is the thing. The real hidden danger, it's happening completely silently, right there in the lungs. When the pulmonary arterioles are chronically exposed to this highly elevated flow and pressure, they don't just stretch out, they structurally change. They undergo progressive vascular remodeling. We start seeing smooth muscle hypertrophy and a thickening of the intervascular walls. Slowly, silently, over years, the pulmonary vascular resistance relentlessly climbs upward. And the craziest part is, the patient might feel absolutely fine while all this invisible damage is permanently locking in. And then we hit the devastating climax of the disease. As that pulmonary vascular resistance keeps climbing, the pressure in the lungs eventually approaches and then actually exceeds the systemic blood pressure. The very second pulmonary pressure becomes higher than systemic pressure, the entire physics of the heart flip. The pressure gradient reverses. And because of that, the direction of the blood flow reverses entirely. Instead of left to right, the blood now aggressively shunts from right to left. This catastrophic reversal is known as Eisenmenger syndrome. Because the blood is now flowing right to left, completely deoxygenated blood is bypassing the lungs and entering the systemic circulation directly. As a desperate compensatory response to this chronic oxygen starvation, the body presents a classic clinical triad: cyanosis, which is that bluish tint to the skin, clubbing of the fingers, and polycythemia, which is a massive overproduction of red blood cells as the body tries to capture whatever tiny bit of oxygen is left. So the crucial point here is how this brings us right back to our opening paradox. As those pulmonary pressures rise and equalize with systemic pressure, the original pressure gradient that drove that left-to-right shunt diminishes, and so the turbulence diminishes. Suddenly, that once loud, harsh, hollow systolic murmur can soften or just vanish entirely. Listen, if a loud murmur suddenly disappears in a known VSD patient, do not assume it's good news. While a defect can spontaneously close in childhood, a vanishing murmur in an older patient means the fatal onset of Eisenmenger physiology has arrived. That silence is literally a siren. At this stage, the process is completely irreversible. You might intuitively think, well, let's just close the hole now. But you can't. By the time Eisenmenger syndrome is established, closing the defect removes the overloaded right heart's only pathway to decompress. If you close that one remaining pressure relief valve, it can precipitate acute right heart failure. Closing the hole at this point will literally kill the patient. The 2025 guidelines, timing the intervention. Because of these incredibly unforgiving physics, timing the intervention is the single most consequential decision a doctor makes. To get this timing absolutely perfect, modern medicine relies on standards like the 2025 ACC, AHA, HRS, ISACHD, and SCI guidelines. The key takeaway here? Doctors do not rely on symptoms or murmur intensity. Instead, they quantify the exact shunt volume using a very specific hemodynamic measurement called the QP-QS ratio. This ratio, usually grabbed via an echo or cardiac cath, simply compares the volume of pulmonary blood flow to systemic blood flow. A ratio of exactly 1 means there's no significant net shunting taking place. But when that QP's ratio climbs above 1.5, well, we've got a major problem. A ratio of 1.5 or greater mathematically indicates a hemodynamically significant left-to-right shunt. It definitively confirms that the heart is experiencing genuine, dangerous volume overload, and it acts as the primary signal that surgical closure needs to be seriously on the table. And this brilliantly illustrates the second half of the equation. While QQs measures the volume, the second, even more vital metric measures survival, pulmonary vascular resistance, which is quantified in Wood units. This number dictates whether a patient can even endure the surgery. According to the 2025 guidelines, if resistance remains below roughly 3 Wood units, the pulmonary vasculature hasn't yet undergone irreversible remodeling, so closure is recommended. In that tricky intermediate zone of 3 to 5 Wood units, decisions become highly individualized at expert centers, often relying on targeted drug therapy trials to see if the lungs will respond. But if the resistance is fixed and elevated above 5 Wood units with Eisenmenger physiology, closure is strictly contraindicated. At that point, the shunt is the only thing keeping them alive. Now, there are a few other accepted, specific scenarios where intervention is pushed for before that irreversible damage sets in. These include patients who suffered a prior episode of infective endocarditis, patients showing clear evidence of left ventricular volume overload caused directly by the shunt, or, as we highlighted earlier, patients with a supracristal VSD that is actively causing progressive aortic regurgitation. So, what do we do for a patient who has already crossed that terrifying threshold into Eisenmenger physiology? The whole management strategy pivots completely. As we said, you must avoid defect closure at all costs. Instead, therapy relies heavily on pulmonary vasodilators, things like PDE5 inhibitors or endothelin receptor antagonists. We start them as monotherapy and often escalate to combination therapy just to manage the patient's severely reduced exercise capacity. But ultimately, for end-stage disease, the only definitive treatment left is evaluating the patient for a combined heart-lung transplant. Real quick before we wrap up, it's absolutely vital to clear up 2 very common points of clinical confusion. First up, routine infective endocarditis prophylaxis, like giving a patient antibiotics before a standard dental visit, is actually not indicated for a simple non-cyanotic VSD. Second, and this is much more severe, pregnancy in a patient with Eisenmenger syndrome is actively contraindicated. The massive hemodynamic demands that pregnancy places on a fixed, non-reversible pulmonary circulation carry a catastrophic risk of maternal mortality. It is just incredibly dangerous. Okay, let's pull this whole picture together one last time. The physics literally dictate the timeline here. A small hole creates massive turbulence, giving us a loud but reassuringly benign murmur. A large hole offers minimal resistance, which leads to silent, dangerous volume overload. Left untreated, that chronically elevated pulmonary pressure forces a catastrophic shunt reversal. That reversal into Eisenmenger syndrome is an irreversible, fundamentally different disease. Everything about our modern medical guidelines exists solely to catch the patient before that transition becomes permanent. Which brings us right back to the bedside. The next time you encounter the mechanics of the human heart, remember how beautifully and sometimes tragically its physical rules operate. Don't let the noise fool you. If the loudest heart in the room might actually be the healthiest, what is the silence in a patient's chest really telling you? I'll leave you to ponder that. Thank you so much for joining me on this explainer. Keep questioning, keep learning, and I'll catch you next time.